Jana introduce.
Okay. Good evening, everybody, and welcome to all the attendees who are with us now. We are starting our ITP meeting, the management of ITP in the era of COVID-19. And with us, we have Professor Walid Ghanima. He's a professor of hematology. He works at the Institute of Internal Medicine in Oslo, Norway, and he will start the meeting, the webinar, by his topic, Management of Immune Thrombocytopenia and Updated Guidelines in the Era of COVID-19.
Okay, thank you, Dr. Aminal, and thanks to AMGEN for inviting me to this webinar. So I will cover two topics today. First is a review of the updated guidelines, covering both ASH guidelines and the international consensus report or guidelines. And then I will touch on how to manage ITP in the era of the COVID-19 pandemic. So simply I'll start, but this is our hospital. It is actually in the southeast part of Norway, exactly this part. And it's about 90 kilometers from Oslo, and here is Oslo, and I have been affiliated with the Institute of Clinical Medicine, University of Oslo. So this is from AMGEN. And then starting with the ASH guidelines. The ASH guideline use the grade approach for making the guidelines. It is the most modern and updated approach for guidelines. This is in contrast to the international consensus, which use the old approach of classifying the strength of evidence, and based on that they make recommendation. So I will tell you a little bit about this approach. In this approach, they will define a number of questions, like for patient with a newly diagnosed ITP, would you treat with prednisolone or dexamethasone? This is a question. And from that, they will go and search the literature, and based on what they found in the literature, they put the result in a software and they come out with numbers. Like if you treat with dexamethasone, you will have a response rate of so much, and with prednisolone so much. In a way, they synthesize the data. And then you have a panel, they will sit and look at the data, and based on this, they will make their recommendation. And the recommendation will be labeled as either strong recommendation, using the word recommend. So whenever you see recommend, it means that almost always it's based on a strong recommendation. Or they will, if the recommendation is weak, they call it a conditional recommendation. They use the word suggest. So whenever suggest, it means that a weak recommendation. And then they make sometimes so-called good clinical statements. So the panel, they can make statements even if they don't have enough evidence. And these statements endorse practices that the guideline panel agreed have an unequivocal net benefit. Not necessarily based, as I mentioned, on a systematic review or available evidence, but even it could be strong recommendation. For example, if a patient comes with major bleeding, will you give platelets or no? I mean, we don't have evidence from studies showing that giving platelets probably, although we have some evidence, but this is just an example. Even if we don't have evidence, they can make a strong recommendation saying that it is logical to give this, it's life-saving. So that sometimes we see it as strong recommendation. So what does a strong recommendation mean? A strong recommendation means for the patient that most individuals in this situation would want the recommended course of action. So if it's strongly recommended and the patient wants this, would want this treatment. For the clinician, means also that most individuals or clinicians should follow the recommended course. And this is important. So if we deviate from this recommendation, then we have to explain why we deviated from this recommendation, because the guideline says they strongly recommended it. For policymakers, the recommendation can be adopted as policy in most situations. So for reimbursement, for treatment, for all these things, they should accept it if it's strong recommendation. And for the researchers, the recommendation is supported by credible research or other convincing judgment that makes additional research unlikely to alter this recommendation. So I'll start first by showing the management of adult patient with, or going through the questions and the recommendations on the management of adult patients with a newly diagnosed ITP. That will be the first 6-7 slides, and then the recommendation or the concerning the management of adult who fails corticosteroid treatment. So the first question, these are how the questions are phrased. Should adults with a newly diagnosed ITP and a platelet count of less than 30 who are asymptomatic or have minor mucocutaneous bleeding be treated with corticosteroids or be observed without treatment? So platelet count below 30, should they receive corticosteroid or observation only? And the recommendation or the panel suggests corticosteroids. I would draw your attention to the word suggest. It's a weak recommendation, conditional recommendation, because low certainty of evidence. So they suggest corticosteroids rather than management with observation if platelets count is below 30, which is usually, that's our practice. Most of us practice it. But then they make a remark. They said, okay, in certain situation, observation might be appropriate in subset of patients. For example, if you, depending on the severity of thrombocytopenia, comorbidities, use of anticoagulants, and age of the patient. If you have a young person, a young patient who probably has had a viral infection recently, and you believe this will go over within a few weeks, and a platelet count of 26.7, probably you want to wait. So this is what the panel adds to the recommendation. The next question, should adults with a newly diagnosed ITP, but this time with a platelet over 30, who are symptomatic or have minor cutaneous bleeding, asymptomatic or have minor mucocutaneous bleeding, be treated or observed? This time, they put the word recommends. So they give a strong recommendation against corticosteroids in favor of management with observation. And this is, even if the evidence is based on low certainty of evidence, but they made a strong recommendation. Again, they put a remark saying that corticosteroids may be appropriate in a subset of patients. This is particularly relevant or pertinent to patients, for example, on anticoagulation. So if a patient of an elderly patient, over 60, 70, or on anticoagulation, you might treat the patient rather than observe. And they put another, this is not a question, but more like a remark, you should always monitor the patient on corticosteroids for side effects. And regardless of the duration, so this is a common practice, we always ask for the potential side effects with corticosteroids. And these are, as you all aware of, hypertension, hyperglycemia, gastric irritation, increased weight is an important, is not here, and osteoporosis, of course, with longer use. And then another issue that I wanted to include here, or not include, but to show that another statement that saying that given the potential impact of corticosteroids on mental health, the treating physician should conduct an assessment of health related quality of life, depression, fatigue. Okay, both guidelines actually says you should follow the health-related quality, assess health-related quality of life. But actually, we don't have a good tool for using in clinical practice. So I don't know what they were thinking when they stated this. I mean, how to follow that? Just asking the patient how you feel, or we don't have for adults good tool. I know that one tool is currently under development. Maybe can be used in the future. Anyway, so from how to treat to another important question is how long you would treat if you have started steroid, and that's a major change actually in this guidelines and in the European, in the international consensus, that the duration of corticosteroids. Would you use a short course of less than 6 weeks or a prolonged course of more than 6 weeks of prednisolone as initial treatment? And again, very few places in this or statements in this guidelines where they use the word recommendation. The one I showed you previously, and this one, they use recommends against prolonged course of more than 6 weeks, including treatment and taper. So they in favor for short course. So if you start with prednisolone, it recommends not longer than 6 weeks. Even if the evidence is not that great, it's very low certainty. We don't know why 8 weeks or 6 weeks is better than 12 weeks. Anyway, that's what the guidelines recommend because we have good treatments now. That's what they explain this with, or justify this recommendation based on a clinical experience. The panel agreed that there was likely trivial benefit in continuing corticosteroid beyond 6 weeks. So the benefit from continuing corticosteroids is marginal beyond 6 weeks, and also we have good treatments now, so that we don't have to expose our patients to steroids for a long period. And then finally, they said that if your patient requires additional therapy, not responding by 6 to 8 weeks, or use another treatment rather than continuing. So this is one of the important recommendation in this guideline and in the international consensus. So come the next one. Would you use prednisolone or dexamethasone? Actually, the ASH guideline says that the panel suggests, here use the word suggest, either prednisolone or dexamethasone, so the same. However, if a high value, if high value is placed on the rapidity of platelet count, if you want to elevate platelet count quickly, then use dexamethasone. Dexamethasone is preferred over prednisolone, given that dexamethasone has shown increased desirable effect with regard to response at 7 days. So it works faster. The next question is, should adults with ITP and platelet count of less than 20 who are asymptomatic or have mild mucocutaneous bleeding be treated as outpatient or be admitted to hospital? Platelet count below 20, should we admit them or can we treat them at outpatient? The panel suggests that if they are newly diagnosed, if the patient is newly diagnosed, we don't know the patient, and is below 20 who are asymptomatic or have minor bleeding, they suggest admission to hospital rather than management as an outpatient. On the other hand, if the patient has established diagnosis, we know the patient does not bleed with a platelet count of 15, so we can manage that patient as an outpatient. And I'm sure that not all of you agree on admitting every patient with even a newly diagnosed patient with a platelet count of 18 or 19 or 15, but this is what the recommendation says, or the guideline says. And then finally, with regard to the newly diagnosed, should adult with a newly diagnosed be treated with rituximab, with corticosteroids, or corticosteroids alone for initial therapy? There are a couple of studies, actually, randomized controlled studies, well-designed, well-powered studies showing that combining rituximab with dexamethasone gives better effect than dexamethasone alone as upfront therapy. However, despite that, the panel suggests corticosteroids alone rather than rituximab and corticosteroid together as initial therapy. But they make a remark: if high value is placed on the possibility for remission over concerns for potential side effect of rituximab, then the initial course of corticosteroid with rituximab may be prepared. If you really want a quick and or you want a high remission rate right from the start, and you're not concerned about the side effects of rituximab, then you might combine the two upfront. This is, as far as I know, not practiced anywhere other than in Denmark. So how about the management of adult patients who are corticosteroid dependent or do not have a response to corticosteroids? So in other words, patients who failed corticosteroids. A certain number of recommendations are made with that regard. It's nicely done, actually, because in the previous guidelines, they just say that that was from 2011, the AMGEN guidelines. It said, if the patient failed steroid, then you splenectomize the patient. If you cannot splenectomize, you can give either TPO or rituximab. Here, they made comparison between these three agents or three therapies, because this is the most widely used three therapies, and dichotomous comparison between them. And each of these are effective, actually. And therefore, the choice of treatment should be individualized on the duration of ITP, bleeding, comorbidities, age, medication adherence, medical and social support network, patient values and preferences, and cost and availability. Actually, the last two are very important. Patients' values and preferences, which the whole ASH guidelines are actually now built on the patient values and preferences, particularly with regard to the second-line treatment. And cost and availability. If you don't have TPO available, we cannot talk about TPO. Or if you don't have rituximab, then we cannot talk about rituximab. So you have to consider all these issues. This is how looking at the data, if we compare the data, that's how when they do the literature search, extract the data from the studies, put them into that software, and synthesize the data. Comparison between splenectomy, TPO, and rituximab. Response at 1 month, you can see highest response is splenectomy. TPO and rituximab around 60 to 70%. How about durable response? 6 months, 50% splenectomy, 60% TPO, 40% rituximab. That is based on the, I know this may varies from study to study, but this is how the data were presented in the guidelines. And how about remission rate, long-term remission rate? 70% splenectomy, which all of us agree on the remission rate for splenectomy is around 70% on the long term, and rituximab 25%. So these are correct. And we know that the TPO mimetics have a remission rate of around 15 to 20% also. Bleeding is 2 to 4%. No difference between these treatments. These are major bleeding rates on these treatments or therapies. So they made a remark: based on the greater durability of response observed with splenectomy and TPO-RA, the panel determined that these two treatment modalities had moderate desirable effect compared with rituximab. What does that mean? That means based on the durability of response, TPO and splenectomy have better effect than rituximab, which is true. How about the safety? Comparison of safety between these three therapies. Splenectomy infections 10%, TPO 7%, rituximab 4%. I think it's unfair to say 7% infection rate with TPO, but that's what the randomized control trial have shown. So these are the data, but we know that splenectomy infection rate with splenectomy is higher than TPO and most probably higher than rituximab too. How about thrombosis? 2.4, 2.5, 2.2. Probably unfair with regard to rituximab if we look at rituximab here. So splenectomy had a moderate, the remark they made, splenectomy had a moderate undesirable effect compared with rituximab because of the potential for operative complication with splenectomy, and that's true too. However, these therapies, I mean, they're not only effect and side effects. These therapies have different characteristics. It's not easy to compare rituximab to splenectomy. One is surgery, another thing is one treatment, and you get long-term remission or response. The third thing is very high response, which is TPO, but you have to take this treatment continuously. So we are often comparing apple to oranges here. And again, what is important is that the patient here, what the patient prefers. So we have to present the data to the patient, the characteristic of these therapies, and let the patient make a decision together with the physician. So TPO, which requiring ongoing drugs, rituximab has more limited exposure, and splenectomy, which imparts of a lifelong risk of complications. This is the central element in, as I've said this already a couple of times now, patient education and shared decision. To have a shared decision making, you have to educate the patient. And this is a central issue in the ASH guidelines and in the international consensus, but more focus on it in the ASH guidelines, which I like it very much. Patient who values avoidance of long-term medication may prefer splenectomy or rituximab, whereas patients who wish to avoid surgery, of course, they may prefer TPO-mimetics or rituximab. Patients who places high value on achieving a durable response may prefer splenectomy or TPO. And no single second-line treatment is optimal for all patients. Therefore, treatment should be individualized. So how these questions are put, should adults with ITP lasting for more than 3 months who are corticosteroid dependent or have no response to corticosteroid be treated with TPO or rituximab? So the choice between TPO or rituximab. ASH guidelines suggest, again, this is a weak suggestion, a TPO rather than rituximab, largely because of a greater durability of response. However, rituximab might be preferable if the patient places a high value on avoiding long-term treatment. If the patient doesn't want or cannot afford TPO, if the patient doesn't want to take tablets every day or injections every week, then the patient choose rituximab. So it's the patient who decides, actually, and we inform the patient. Should adult with ITP lasting more than 3 months, the same thing, who fails corticosteroids, undergo splenectomy or be treated with rituximab? The ASH guidelines suggest actually rituximab rather than splenectomy. And that because we might avoid some splenectomies if we give rituximab. Should adult with ITP lasting more 3 months, the same question, but should undergo splenectomy or treated with TPO? This time they give equal or suggest either one of the two, TPO or splenectomy. However, this is a very important remark. For patients with ITP of less than 12 months duration, it may be preferable to delay splenectomy when possible because of the potential for spontaneous remission in the first year. So they suggest, or it's a strong suggestion in a way, that during the first year, try to avoid splenectomy because your patient may have high chance or probability of going into remission, whatever you treat the patient with. Patient preference is important. Value avoidance of surgery or long-term treatment. So they should decide whether they want to avoid surgery or long-term treatment. And finally, if we first of the patient decide and we decide to give the patient TPO mimetics, would we choose eltrombopag or ramiplastim? The guidelines or the panel suggest either one of the two because we know they are equally effective. They are different administration patterns and routes and side effect profile are more or less the same with some differences. So individual, I always ask the patient whether prefer an injection once a week and that's all, or prefer daily tablet and you have to take care not to eat, not to drink milk or such dairy products before and after, so the patients take the decision, him or herself. There's no direct comparison between the two, only indirect comparison between them, and there's no difference in the outcome or responses or bleeding response, bleeding rates or rate of corticosteroid discontinuation or reduction. So they're equally effective regarding all these outcomes. And no difference in undesirable effect was determined, or the difference actually in undesirable effects was considered to be trivial. Transaminitis with eltrombopag is encountered in about 10% of the patients, and we have to follow up with regard to the liver function test quite frequently during the first year. What's also nice in this guideline is the ASH guideline, they present this algorithm, treatment algorithm, and you have to decide where is your patient, is in the 3 to 12 months or more than 12 months. One point I want to draw your attention to, if you remember steroids, they do not recommend longer than 6 weeks, and probably 8 weeks or something like that. So here they are saying, if the patient fails after 3 months, what should we do? So what the gap between 8 weeks and 12 weeks, it's not really addressed. So shouldn't have stated it that way. But anyway, we would say that if the patient fails steroid and it's less than 12 months, what should we do? So we have two choices, rituximab or TPO. And then you ask the patient, assess the patient values and preferences. Patient who places high value in achieving durable response, give TPO. Patient places a high value on avoiding long-term medication, give rituximab. If the patient is more than 12 months, has passed more than 12 months, then you have the splenectomy option to the two others. And then the same questions you ask the patient and you discuss with the patient, where do they value, what do they value mostly? If a patient places high value on achieving durable responses, then treatment options, splenectomy or TPO. And then if the patient places high value on avoiding surgery, then it's TPO. Or if the patient wants to avoid long-term medication, then splenectomy. And in this way, we continue. So actually, this is useful. The only thing that we don't have a good patient information in a way unbiased. What I feel we need is a set of information presenting these data, advantages and disadvantages, all these treatment, unbiased. It's not like I like rituximab, then I will of course speak warmly of rituximab and convince the patient, or I like Nplate, so I will try to, in a way, influence the patient decision. So I think we need more good patient information. So how about the updated international consensus report? This report Also, it's 10 years since the last one or the first one, and they used or we used the older classification of evidence, which is based on the evidence level, and then based on this, one can make the recommendation. So starting with the goals of therapy, treatment goals should be individualized. So this is important. We should individualize the patient treatment to patients. Very much focus on both guidelines on individualized treatment. And treatment should prevent bleeding. We know that. Treatment should maintain a target platelet count of 20 to 30. So here the cutoff is slightly lower compared to the ASH guidelines, which says 30. Treatment should be with minimal toxicity, and treatment should optimize health-related quality of life. And again, as I mentioned, we don't have a good tool to measure health-related quality of life. And fatigue should be considered. We should ask the patient about whether it's fatigue and try to increase platelet count and see if it helps. Who should be treated? Treatment is rarely indicated patient with a platelet count over 20. In the absence of a bleeding, trauma, surgery, comorbidities. That's what the guideline says. I think it would have been better to say over 20 to 30. I tried to influence them here and change the 20 to 30, but obviously I forgot this issue to influence the panel and add the 30. I think it's more correct with to add the 30. Anyway, patient preferences must be considered. That is exactly the same way as the ASH guidelines. So how these guidelines are structured? The either initial treatment, which comprises corticosteroids, anti-D, IVIG, or subsequent treatment. And with subsequent treatment, we have the medical or the surgical. And the medical, they are divided into those with robust evidence, eltrombopag, romiplostim, avatrombopag, fostamatinib, and rituximab. And those with less robust evidence, having no randomized controlled trial, and then splenectomy. So with that, it's the same here. They recommend not longer than 6 to 8 weeks of treatment with corticosteroids, rapidly tapering if no response within 2 weeks. And if we get a response, then we should not give more than 6 to 8 weeks. Sometimes in these guidelines, we open for a low dose, which might sometimes be beneficial. Some patients respond very nicely to low dose of prednisolone. How about subsequent therapy? We know that up to 30% may go into remission in 1 year, and up to 80% within 5 years. And if possible, splenectomy should be deferred for more than 1 year. This is the same as the ASH guidelines. And the main goal of subsequent treatment is to attain a sustained increase of platelet counts. This is the most important thing, is to keep the patient in a safe platelet level and hope that the patient will go into remission. So quickly going through these treatments, I mean, the TPOs, first, they have the excellent response rate, about 60%, same as what I showed you with the ASH guidelines, and the highest grade of recommendation given to this treatment. Usually response continued on TPO for 6 to 8 years. We have knowledge that as long as treatment is ongoing, so they don't lose response. And sometimes we can discontinue and platelet or decrease the days, discontinue TPOs or decrease the dose. And some of the patients, 10 to 30, will achieve durable response after discontinuation. How about rituximab? Initial response rate, 60%. However, half of the patient loses their response with time. Within 2 years, only 30% probably, or 25 will remain in response. It's a grade B recommendation. And if we treat with rituximab, we have to remember that hepatitis B status should be determined, and vaccination against encapsulated gram-positive bacteria should be given. How about fostamatinib? Response rate about 40%, and well, that is an overall response rate, but the stable response rate's around 20%. I think it's still not licensed yet in Europe, but it's licensed in the United States, and I don't know. It was supposed to be licensed during 2020. So, conclusion of the two guidelines: the main element, there is agreement that prolonged exposure to steroids, more than 2 months, should be avoided. Splenectomy should be deferred for more than 1 year. Use of therapies with robust evidence first, as TPO, rituximab, fostamatinib, and individualize a treatment to obtain balance between efficacy and tolerability. So that was the first part of the presentation, and then I have a few slides on the second part of the presentation with managing ITP during the COVID-19 pandemics. And these guidance are based from the British Society of Hematology, which you can find these guidance on their website. I try to summarize it and make some changes sometimes. So generally, thrombocytopenia occur in about 40% of COVID-19 patients, but usually not very low thrombocytopenia. It's in the 80, 90 or something like that, the thrombocyte count. But if the platelet count drop to less than 20, then this may indicate an autoimmune or an immune etiology. You have to work up and do a diagnostic workup to find out if it's ITP or not, to exclude other causes of immune thrombocytopenia. COVID-19, there's no evidence that COVID-19 predisposed to ITP. There's a webinar which I'm going to provide you with the link. There was people from Francesco Rodigero from Italy, and Wu from China, and other experts from around the world, and actually none of them, not in Italy, they've heard of increased rate of ITP or neither in China. So there's no evidence, but Nicola Cooper in Hammersmith, she's seen a couple of cases, and there's been a case in the New England, a short case also of an ITP patient. And there's little evidence to inform the optimal management of ITP. So all these are based on guidance and recommendation, which I'm going to state to show you now. They are based on logic, not on evidence. So the first thing to do is, when we manage a patient with a newly diagnosed or relapsed ITP, is to test for COVID-19. And if it's negative, and the patient require treatment, then try to minimize hospital contacts. The only thing we want to do, probably, that we don't want to bring the patient often to the hospital, expose the patient to the risk of infection from other COVID-19 infected patients. So that's the main issue, how to reduce this. Probably TPO is the best thing in that setting. Steroids, okay, you can probably use, although there is generally we want to consider avoidance of immune suppression. We don't know if immune suppression is beneficial or harmful to the patients. Might be beneficial. There's no indications that steroids pose a higher risk of development of COVID-19 infection or worsening of symptoms. But the WHO in general, they recommend avoidance of steroids if there is alternative treatment, and even no indication that rituximab increased the risk of COVID-19. I don't know if you have any experience, but if you have seen worsening of ITP or due to COVID-19. Anyway, this was a new patient. How about managing a new or a relapsed patient, but this time with COVID-19? The patient has an infection. The previous one was patient doesn't have an infection. And if the patient requires treatment, then consider avoidance of immune suppression. And here we have to consider the risk of thromboembolism. Probably IVIG is the best option. We admit the patient to the hospital if that requires treatment. IVIG probably is the best choice here, as I mentioned. May reduce the use of mechanical ventilations. There is some evidence, and promote earlier recovery. Steroids may be used, but we should consider risk of secondary infection and delayed viral clearance. Keep minimum dose duration if you have to give steroids. Tranexamic acid is also can be used, and platelets can be used. TPO probably should be avoided because of the risk of thromboembolic complications. So if the patient is on, has the infection, because COVID is very thrombogenic disease, so probably we should avoid. Although this case in the New England, they used TPO. How about patient with a stable disease? A patient with chronic ITP, stable on a treatment, not COVID-19 patient, remain on the same, don't make any change. Patient with splenectomy are probably not at an increased risk of COVID-19. We don't know what we believe they are not at increase. Reduce the frequency of follow-up if possible. Appointment conducted by telephone or online platforms if possible. So you call the patient, check the platelet count, and manage the treatment accordingly. These are 3 links to a couple of webinars and guidelines also. And finally, thank you very much for your attention. This is one of the paintings we have to illustrate the social distancing. So.
Okay, thank you, Professor Walid, for this very informative presentation. Of course, the floor is open for discussion. And I would like to ask about the steroids in COVID-19 positive patients. Don't you fear a little bit from them, the use in the ITP in these patients, or thrombocytopenia in these patients?
In patient with COVID-19 or a patient with ITP but not COVID-19?
With COVID-19, I think it's not.
No, it's not that very much recommended. I think it's better to use. I mean, that's what I tried to say. Also, that yes. Actually the evidence, we don't have the evidence, but. I feel everybody wants to avoid steroids now, yes. and it's reasonable. So we have other alternatives. Why steroids? I think IVIG is a very good alternative.
Yes. Thank you very much. And now I think the floor should be open for discussion now. Questions from the audience, please.
Have you any experience with?
So if there are no more questions now, we can move further. Of course, we thank Professor Walid Ghanima for this very valuable presentation. And I think up till now, I don't have any questions. It seems that it's very clear. And we can move to the next speaker, Professor Ashraf Al-Ghandour. Okay. Now our next speaker is Professor Ashraf Al-Ghandour, and he will give a presentation about the diagnosis and management of ITP, immune thrombocytopenic purpura.
Hello, everybody. In such time of lockdown, it's okay. First of all, I would like to thank Professor Manal for getting this activity through HemoAlex. I think we all miss HemoAlex. It will be coming soon, I know. However, it's thank you, Professor Walid. Really, I enjoy it. Thanks, AMGEN, for such sponsoring for this meeting. What we are going to talk, it's not treatment, it's how you can diagnose ITP in our region. Actually, I think many of us see a lot of ITP or thrombocytopenia in his clinics many times in each day. So thrombocytopenia, it's okay, as we know, that's if it's below above 50,000, we have no symptoms. Up to 20,000 symptoms generally need to begin therapy. It's as symptoms with bleeding or sometimes bleeding. Below 10,000, which it's life-threatening. Below 10,000, which it's a risk for spontaneous intracranial hemorrhage. We are speaking here about ITP, not new else. ITP, it's immune thrombocytopenia. Platelet counts below 100 is established as threshold for diagnosis. Only terms relevant for treatments we can classify it as new diagnosed ITP, persistent ITP with more than from 3 to 12 months, chronic ITP more than 12 months. Although certain guidelines give it chronic ITP more than 6 months, whatever. Here it's chronic, is either persistent or chronic. It's almost the same in management. Treatment response here, it's when you have platelets more than 100, it's called complete remission. Response here is between 30 to 100,000. Below 30, no response at all. Duration response here should be calculated from time of complete remission or response until complete remission response. Okay. Its definition we have, as we all know, that it's isolated thrombocytopenia with no clinical apparent associated conditions or other causes of thrombocytopenia. Etiology here, it's maybe autoantibodies directed against platelets, coating platelet surface. Incidence here, 100 per million. I think in Egypt we may facing more than this incidence. I think 200 or 300. Half of these are children. In adults, 2 peaks. We can see it below 40s or above 60s. Below 40s, more with male. Above 60s, no gender predominance. This is a bar chart with the different ages, and as we can see from here, it's 15 years old or 25 years or 23 years. It's predominant in females, and then it's as equal for both sexes. When you have patient with low platelet count, you must take history, this is a very important question here. Has the patient ever had a normal platelet count? This is very important because he may have chronic thrombocytopenia or not, but it's very important in that issues. You must ask this question: does he have any previous CBC? We should carefully review medications, especially OTC medicine with the patients, antibiotics, quinine, anti-seizure medication, which may lead to low platelet count. We should ask about other conditions which may be associated with low platelets. In this pathology is accelerated platelet destruction due to phagocytosis of antibody-coated platelets by the reticular system in spleen, liver, and bone marrow. Phagocytosis is mediated by in the spleen, which recognize Fc domain of IgG type. This is important. What about thrombopoietin level? As we can see here, with low platelets level, TPO is a little bit not so high. Or in aplastic anemia, we have a maximum endogenous erythropoietin elevation, which means here it's antibodies or immune system more than deficiency of TPO. Let's go few years, how much years ago, in Harrington classic experiment. In classic 1951, Harrington volunteered to infuse himself with blood from an ITP patient, quickly developed severe but transient thrombocytopenia. He later recruited several volunteers to undergo the same experiment. Most of otherwise healthy subjects had similar levels of platelet destruction and recovery as that of ITP. These experiments confirmed that there was a thrombocytopenic factor in ITP plasma. At diagnosis, what is you recommend for diagnosis? For basic evaluation, here you must do patient family history is very important. Physical examination, complete blood count analytic system, because it may be Evans syndrome. Peripheral blood film, you may facing other causes of thrombocytopenia. Quantitative immunoglobulins, here, measurement, we prefer it. Bone marrow examination in select patients, and we're going to go through in the next few slides. Blood grouping RH, which is not actually now it's important because we have many other options. Direct antiglobulin test, H. pylori, HCV, anti-IV in certain areas, which we have a lot of cases of H. pylori here, and a lot of cases HCV show it's, I think it's mandatory. What test of potential utility, which is not must be done? Glycoprotein specific antibodies for immune system, anti-phospholipid antibodies, anti-thyroid antibodies and thyroid in function, Perkins test in female of child-bearing potential, anti-leukerin antibodies, viral PCR for parvovirus and CMV. Test of unproven benefits you must not do. TPO level, reticulate platelets, antibody IgG, bleeding time, platelet survival study, and serum component, which is not important in such issues. This is estimated prevalence of secondary ITP in the US. 80% of cases, as we know all, it's primary, while 20% present this all cases, symptoms, antiphospholipid syndrome, CLL, Evans, whatever. Hepatitis C, which is here in Egypt, is not 22%, it's much more than this level in cases of ITP. Actually, here in Egypt, if you find the case of thrombocytopenia, first you must exclude thrombocytopenia associated with hepatitis C. What about antinuclear antibodies in ITP? Yes, it's a little bit, you must exclude it because you may have a lot of cases with A positive cases. And as we see here, from 18 cases, we can find 4 cases in the past of systemic lupus. So you must exclude antibodies of antinuclear antibodies in ITP. This is a very important question. Tomorrow or not tomorrow? Bone marrow aspiration both indicate if patients 60 years or older, it must do because he may have MDS, myelodysplastic syndrome. If the patient, whatever age, poorly responsive to treatment, may have Fanconi's or starting aplastic anemia, or unclinical clinical picture, unexplained clinical picture, you must do in this session bone marrow. Antiplatelet antibodies testing, it's not recommended by AMGEN practice guidelines. You must not do or give anti-nuclear antibodies. Okay. Poor positive negative predictive values, poor sensitivity with all current testing methods, and does not change the management. Here. What about new recommendations or whatever recommendations for ITP evaluation? Quantitative immunoglobulins sometimes may be of help. This should be done before patient receive intravenous immunoglobulins. This will reveal patient with CVID and variable immunodeficiency or IgA deficiency associated with thrombocytopenia. So if you are decided to give immunoglobulin, you must exclude this subtype. Direct immunoglobulins, which is antiglobulin, which comes test, which is very, very, very important in cases. A positive direct antiglobulin test was reported in 20% of cases with ITP. It's important if the patient has anemia and or high retic count. So it's very important. Blood grouping, if you are going to do anti-RHD, which is not used as usual as that period. Additional test, yes. Thyroid antibodies and TSH, look, up to 14% of patients with ITP can develop clinical hyperthyroidism. The presence of hyperthyroidism or high dose can result in resistance to standard ITP therapy. It's a very important issue. If you have patient with resistant ITP treatment, you must do thyroid antibodies, syndrome antibodies, or TSH, because you may have hypo or hyperthyroid. In children, which is not performed in it's in case of chronic ITP, in patient with history of either fetal loss of thrombosis, screen for anti-fluid antibody is mandatory. So you may have both thrombosis and thrombocytopenia at that time. Lastly, here is our key points. Recommendations for target platelet counts during surgery. As we know, it's for dental prophylaxis, 30%, simple extraction, 30,000, complex extraction, 50,000, regional dental block, 30,000, minor surgery above 50,000, major surgery above 80,000, major neurosurgery 100,000. I think by this slide, I thank you for your attention, and waiting for Dr. Manal and her questions. Thank you very much.
Okay, thank you, Professor Ashraf, for your nice presentation. I have a question here from Professor Walid Ghanima. He was asking about the H. pylori associated thrombocytopenia. What is the experience with response to H. pylori treatment?
Dr. Reid, this is a good question. As in case of mild, we can see it in mild thrombocytopenia. A lot of patients have or have whatever H. pylori association. So we give treatment, and actually in our experience, a little we can see a little bit rising of platelets in such condition. Okay, and sometimes in case of ITP and its resistant treatment, we can find overlap with the H. pylori cases. Okay.
Okay, another question here. When do you consider testing for hereditary thrombocytopenia?
Family history, first of all, of present family history or positive consanguinity, because it's associated with here for family with the familial one. Okay, and we have also question, Dr. Manal, from Muhammad Samra, Q&A. Can you see it?
No, I don't have it here.
Okay, it's in Q&A. Dr. Muhammad Samra asking, which is very tricky question. I know. Dr. Muhammad Samra, a rheumatologist.
Why it is
in your practice, in Q&A, in your practice, do you have bone marrow aspiration at diagnosis? Yes, if above 60, as per international guidelines, or no, respective of age. أنا ما أعرفش this question ولا لا. and I stated that Dr. Muhammad, and if you have patient with elderly with more than 6 years of old age, you must do bone marrow aspiration to exclude MDS. Below that, we usually don't do it. Okay, Dr. Manal?
Okay, there is another question. Did you experience any cases of secondary ITP that turned to primary ITP? I don't know how this can happen, but this is the question.
You know what? I think the audience mean that you may have a hepatitis C patient with secondary, with thrombocytopenia, and after following treatment with hepatitis C and PCR negative, here we are facing thrombocytopenia. Is it primary ITP? No, we still have hepatitis C antibodies, which is considered still secondary. Okay, to Professor Manal.
Any other questions? Okay, so I think there are no other questions for you, Professor Ashraf. Thank you for the nice presentation. And we'll move to the next speaker.
Good evening, everybody. It's my pleasure to be here with you from home. It's first time for us to be with you from home. It's my pleasure, and it's an honor for me to present the next speaker. The next speaker will be Dr. Mirbat Natar. But first, I want to thank AMGEN Group for this meeting and this presentation. It's my pleasure to present now Dr. Mirvat Nasser. Dr. Mirvat Nasser طبعا is it's big name in the hematology. It's professor of hematology and bone marrow transplantation in Cairo University, our partner, and it will be her presentation about ITP, current guidelines and emerging therapy. ويعني الفلور للدكتوره ميرفت دلوقتي عشان نسمع طبعا يعني المحاضره الجميله. اتفضلي يا دكتور ميرفت.
Thank you, Dr. Mohammed Moussa, for this very nice introduction. I thank you very much. I miss you and I miss you all. كلكم يا جماعة, I miss you very much. I thank AMGEN for letting us meet and also meeting with Dr. Walid Ghanima, which is very nice. Dr. Ashraf, Dr. Manal, Dr. Azazi, Dr. Muhammad Samra, and all of the audience. I'm going to talk about first-line therapy here. And so I need to show you first what does ITP have in common in Egypt. And we collected in our series 350 adult ITP patients. And among them, I have to show you that females were much, much higher than males, 82%, while females were 18% out of 150 patients. Median age in our series was very young, age of 30, and bleeding was 88% in all cases. The age range was between 14, as young as 14, and as high as 70 years of age. طبعا, the very first manifestation was cutaneous bleed, and this was followed by gingival bleed in our series. We joined others, whether in our Egyptian experience or with an observational non-interventional multi-center study of immune thrombocytopenia, including Africa, Middle East, and Asian immune thrombocytopenia registry. And we showed them that in our series, we had more females than males, younger ages, and the median duration of ITP in our cases was 2.5 years. The duration of disease ranged between 1 month and 21 years. Most of the cases were neurodiagnosed, but 45% were chronic. Now, as Dr. Ashraf, my dear colleague, has just mentioned, we do certain lab tests to exclude other causes of thrombocytopenia, to exclude secondary causes. And anti-nuclear antibody was positive in 13.3% of cases, while hepatitis C was positive in 14% of cases. Hepatitis C antibody. This is not for the PCR, this is just for the antibody. But there are others that are positive. There was a question about H. pylori antigen. H. pylori antigen was positive in 6.6% of our cases. And so a potential underlying etiology was found in around 40% of our cases. Now, as you can see, this is how the newer guidelines look like. And I'm going to concentrate on first-line treatment and see if this can be applicable in Egypt. When to treat? Treatment is rarely indicated if patients have platelet counts around 20,000 or more in the absence of bleeding due to platelet. They have to be bleeding because of the count is low, or because of platelet dysfunction, or because of another known or unknown hemostatic defect, maybe trauma or surgery. Clearly identified comorbidities for bleeding mandate antiplatelet or maybe mandated antiplatelet or anticoagulation therapy. We are usually faced with patients that are receiving aspirin or receiving anticoagulation because of heart problems or others, and they are thrombocytopenic. Another problem with low platelets is the fatigue or other non-hemorrhagic complications of ITP, which I'm going to stress, because ITP is not only a disease of low platelet count and bleeding. Also, persons that have a profession or lifestyle that predisposes them to trauma. So we need the platelet count to be more than 20,000. And of course, patient preference. Now, immune thrombocytopenia, chronic immune thrombocytopenia does not only cause bleeding, but it can affect the quality of life. Quality of life with chronic ITP, it can sometimes be worse than patients with hypertension, arthritis, or even cancer. And they are similar to patients with diabetes. And we joined the IWISH study, which included 14 countries and around 1,400 patients. And we contributed by 60 patients by the surveys, asking patients about their symptoms and what is bothering them. And the preliminary results that was published in the EHA 2018, and it showed that 35% considered healthy blood counts to be the most important treatment goal, followed by increasing my energy levels. That means that they are really suffering from low energy. Now, first-line therapy goals including treatment that should prevent severe bleeding episodes, of course, treatment that should maintain a target platelet level of more than or equal to 20 to 30 times 10 to the power of 9, at least for symptomatic patients, and minimal toxicity with optimizing of health-related quality of life. And as you can see, treatment options for ITP include immunosuppression as first line, reusing corticosteroids, IVIG, anti-D, and others. Now, with corticosteroids are used, we all know, because they decrease platelet clearance, they increase platelet production, and they may reduce bleeding via a direct effect on blood vessels. Now, as Dr. Walid Ghanima has just mentioned, whether to choose between dexamethasone and prednisone, it has been mentioned that high-dose dexamethasone can give faster responses without additional toxicity, but you have to use acyclovir to minimize the potential of herpes virus reactivation. Now, high-dose dexamethasone in Egypt is usually given intravenously. You can use it orally, but probably it gives very bad GI side effects. So some patients, they cannot tolerate the oral high dose. Adding rituximab to dexamethasone can be considered, but it is not usual. Now, the use of methylprednisolone is high dose gives 80% response rates. And I have to point out that methylprednisolone upfront with high dose is very common to be used in Egypt. However, maintenance therapy with oral corticosteroids has to follow this methylprednisolone, and this is not recommended in for long term. In our experience, among 300 ITP patients, 288 were indicated for therapy, but 12, they did not need to receive any therapy. Among the 288, all of them, they started steroid as first-line therapy, with 40% achieving a complete response, but 60% of failure of response. Regarding IVIG therapy, 0.4 grams per kg per day for 5 days, it is used in treatment-naive adults with severe ITP, and it results in rapid response of platelet counts in 36.4% of patients, especially those with a special kind of anti-platelet antibody, the anti-glycoprotein 1b antibodies. However, the response to IVIG is only transient, and you have to repeat the IVIG. And in Egypt, this is very expensive. It's an expensive tool. And of course, it has to be given intravenously, not subcutaneously. The subcutaneous IG immunoglobulin does not function properly. Now, anti-D has been used for a while in Egypt. I cannot find it very easily in Egypt these days, but we used to try it. The overall response rate was 65% with a median duration of remission of 25 days. So it's still a transient mode of action. Administration of anti-Ds usually can be associated with chills, pyrexia, evidence of hemolysis in some patients. It can be used with caution in patients with already active autoimmune hemolysis and anemia. There is a black box warning with the use of anti-D, which is given intravenously, for the risk of intravascular hemolysis and ITP leading to death, anemia, multi-system organ failure, and others. And so administering corticosteroids with anti-D can help as a pre-medication. But then you are giving steroids, so why don't you give the steroid for ITP instead of adding it to anti-D? This is not very feasible. How about the use in emergency? Because some people present as an active first-line ITP by an emergency situation. You have to do general measures such as stopping drugs that can reduce the platelet function, for example, non-steroidal anti-inflammatory and others. You have to control the blood pressure. You have to inhibit the menstruation if there is menorrhagia, and try to minimize trauma. You go for platelet transfusions, but be careful with platelet transfusions. You only give them if there is an emergency bleeding. And you can add with them IVIG to try to stop the destruction of the transfused platelets. A platelet transfusion increases the post-transfusion platelet count by around 20,000 in 42% of bleeding ITP patients and may reduce bleeding. Of course, you can add tranexamic acid and aminocaproic acid because this stops any bleeding. Use of these agents also increases the risk of thrombosis, so please be careful. And has been tried to give maybe recombinant factor 7 because recombinant factor 7 stops any type of bleeding, but this is not recommended in the recent guidelines at all. So please be careful with that. In emergency medications, you try to change from corticosteroids if they are not working to IVIG or anti-D. Or you either do this or combine corticosteroids with IVIG or anti-D, or you go back to the high-dose methylprednisolone with all its side effects, and you think of platelet transfusion, possibly combined with IVIG, or you might even reach the decision of emergency splenectomy. Emergency treatment options other than what has been mentioned are these medications that can act on B cells. And so you can consider vinca alkaloids that give rapid responses of 71% at 7 days and 68% at 1 month. And they are given intravenously in weekly doses of vincristine or vinblastine. However, this is not durable response. The durable response rate is only 28%. And of course, there is significant toxicity. I have to mention neutropenia and I have to mention peripheral neuropathy. Romiplastim or other TPOR receptor agonists, TPOR agonists, can be used in emergency situations. However, they take 5 days to initiate a response. And this goes also for rituximab, which usually takes 3 to 4 weeks. However, early administration of these medications, along with other more rapid medications, might be considered to stop the lowering of platelets later on. I have to show you the adult hematology experience in ITP in Qasr Al Aini Cairo University, because this is the second-line therapy in 300 ITP patients after 1 year of therapy. And as you can see, we used many kinds of therapy with different response rates. And I have to show you that L-Trombo PAG and romiplastim gave a 50% response, while rituximab gave a 60.7% response in comparison to splenectomy, which gave 46% response, among others. Now, regarding pregnancy, some patients present by ITP during pregnancy, and they did not know that they had ITP before. And I have to show you that platelet count between 20 and 30,000 in a non-bleeding pregnant woman is safe, and that 50,000 is preferred for delivery, not more than that. Initial treatment is with, of course, with oral steroids or intravenous immunoglobulins that has to be given several times during pregnancy. It can provide a rapid but often very transient increase in platelet count, and it is used to urgently increase the platelet count during bleeding or for delivery. High-dose methylprednisolone in combination with IVIG or azathioprine can also be used. Rituximab can be used for very severe cases, but beware, because this is going to decrease the B cells inside the pregnant lady and afterwards inside the baby. And so beware of perinatal and neonatal immunosuppression and subsequent infection. TPO receptor agonists can be used in late pregnancy with other treatments where other treatments have failed. And of course, lately, I mean, if nothing else helps, you can go for splenectomy also, but only in the second trimester. I think I'm going to stop here, and I'm open for questions. Thank you.
Thank you, Dr. Merva, for this marvelous presentation and very basic up to this presentation. It's time for the questions from the audience. There's a question about what are the types of vaccines that may be predisposed to ITP.
I'm sorry, I could not hear the question. Types of vaccines
that might be exposed to ITP.
I do not know of any. There are many that were incriminated, but we really do not know. I mean, it has been mentioned that maybe MMR could help in producing ITP, but I don't think that there are any real studies that can incriminate any type of vaccine. I don't know if Dr. Walid Ghanima is here to answer this question. I'm not aware of any study, a randomized trial that shows that any vaccine can cause ITP.
I think so. I'm with you. I think there is up to date no vaccine that might cause ITP. There is other question about the diagnosis of the secondary of the ITP in pregnancy. I think what's the difference between ITP in pregnancy or thrombocytopenia with pregnancy? There is a big difference.
This is very true, because thrombocytopenia can only occur during pregnancy, and then after labor, the platelet count then becomes normalized again. However, you cannot rule out immune thrombocytopenia as a first presentation with pregnancy. So it really, from my point of view, it really depends on the platelet count rather than the etiology of the thrombocytopenia. Do you think that too, Dr. Muhammad?
Yeah, and I think also it will be the only difference would be about the extent of the treatment for the patient. If it's thrombocytopenia pregnancy, when the pregnancy will terminate, everything back to normal, the patient is back to normal completely. But ITP pregnancy, the patient will continue with thrombocytopenia and it will need progressive treatment. And I think this type of ITP with pregnancy and after termination of pregnancy and resistance of thrombocytopenia, it will be a resistant case. It will be a resistant case. It's aggressive from the start. Dr. Walid Ghanima agreed with you about the vaccines, Dr. Meba. Is with your
that
opinion
there is no
about
vaccine we can incriminate in the formation of ITP.
Yes, there is another question about switching between the TPO agonist types. How you can shift between the two types of the TPO agonist?
Would you like to reserve this question after Dr. Azazi's talk?
I think so.
I think so too.
Yes, I think so. I think if Dr. Azazi didn't answer this question, we can talk about it again.
Yes,
and also the combined use of both of TPO agonists. The combined use of both of them, they can be combined use or no?
I think they can, but we'll wait for Dr. Azazi's talk.
We'll wait for Dr. Aziz, yes.
مش هنحرقها.
Yes. There's another question, but it's Dr. Walid, about the hydroxychloroquine in ITP with COVID-19.
It's for Dr. Walid to answer?
But Dr. Walid is not here now, I think so.
Oh, I'm sorry.
Could you answer this question about the role of hydroxychloroquine in ITP patient with COVID-19?
I'm not aware. I know that there was a paper about COVID-19 causing thrombocytopenia, but I'm not aware if the treatment of COVID-19 by hydroxychloroquine can help this thrombocytopenia to be better. It was published in the New England Journal of Medicine, I think.
I will ask the question by another way. Do you have any patient with ITP on hydroxychloroquine?
For ITP specifically,
yes,
or
ITP.
For secondary ITP?
For ITP.
It was another problem.
No, for ITP by itself.
Me, myself, no.
No, I have a lot. I use it only with resistant cases of ITP. If the patient is not responding to the first line and then to the second line of treatment, I met with azathioprine, hydroxychloroquine for the patient to modify the immune response, and they get a good response. So if the patient
even if the patient is not lupus or rheumatoid associated,
even
just primary ITP.
Yeah, primary ITP. It gives us a good result with this type of patient. So he's thinking about what about the use. What about the use of hydroxychloroquine in the patient with COVID-19? There is a trial today that the use of hydroxychloroquine in COVID
increase the death rate.
Increase the death rate and with multiple complications. Dr. Walid said also they are using. He's with me. He's using hydroxychloroquine in France also, like in Egypt, as the resistant cases of ITP.
Well, this is good to know, but not with COVID-19 thrombocytopenia then.
No, but not the question about the use of it in the patient with chronic ITP in the era of COVID-19. So if the patient got COVID-19, he thinks that he might be got an improvement with the hydroxychloroquine. But the trial which published yesterday about the use of hydroxychloroquine, there is a lot of debate about it. And I think
let me tell you that COVID-19 infection, I think, is a hematology disease rather than a lung disease. So I think we need to be supporting these patients on our own. We need to handle this, I think.
I'm with you. I'm with you. We are making a big trial now after the approval of the Prime Minister. It's about the use of the drugs of the methemoglobinemia as a primary, as a treatment for the COVID-19 severe respiratory distress patients. Okay. I think there is no answer question now, Dr. Mervat. And thank you, Dr. Mervat, for this presentation. And I think everyone with me agrees that it was marvelous presentation. Thank you, Dr. Mervat.
Thank you, sir, for the very nice discussion.
Next time, for the second time, I want to thank AMGEN for their help in these presentations and for the audience and everything. And it's my honor now to present my chairman and the chairman of the benign hematology and bone marrow transplantation unit in Ain Shams University. It's Dr. Mohammed Al-Azazi, professor of hematology and BMT and internal medicine at Shams University, and one of the pioneers in the hematology in Egypt. He will talk about the ITP treatment strategy and update in the second line treatment of adult ITP. It's your Dr. Al-Azazi. شرف لينا ان حضرتك تكون معنا.
Thank you very much, Mohammed. Of course, it's an honor to be among such elite speakers. وكل سنة وانتم طيبين أولا. And looking forward to resume our scientific activity. And I thank AMGEN to be one of the companies that were ahead of our schedule to do lots of presentation and lots of scientific activity. Hopefully, we continue. To cut short the story, it's difficult to speak after Professor Mervat Matar. She always attracts all the audience and she always covers the subject very well. But my objective is going to be a little bit simple. I'm going to talk about ITP current treatment strategy and the updates that were published only 1 year ago, considering second line treatment. And let us start. This is the platelet. It's not a cell, it's a full active organ. The platelet can attract, can move, can adhere, can secrete, can contract, and can even speak to other cells. So it's rather an active organ with many functions of a full organ. So I call it the smallest but the most active organ in the body. This can be well illustrated if you look here, and you're going to see the platelet can function in different way. This is a quiescent platelet that will act when it gets activated by collagen or fibrin or whatever, and it will secrete, and eventually it will lose its function. Again, this is the function of the platelet. This is a provoked multiple platelet functioning together, and this is the electron microscopy of an activated platelet that has sent its structures all over the tissue and have interacted with the endothelium, with the red cell, the white cell. So this is a complex action, complex organ, and function differently. Not only that, but if you are looking here, you will find that this structure have so diverse function. For example, if you look to A, this is the platelet inhibitions. Many factors interact together. The initiation of platelet activation is through laminin, collagen, fibrinogen, von Willebrand factor. Again, an armament of factors will interact together. This is the release process governed by ADP and the thromboxane complex. And then you go to find multiple complex function of the platelet. Remember that those functions are very crucial to understand what are we going to talk about. My agenda is simple: current treatment strategy, recent current treatment strategy, TBO, whether receptor agonist or not, state of the knowledge after 10 years of their introduction into the market, and few novel therapies in the management of ITP. First, what determines the choice of therapy for the second line, is it the availability of the drug, the cost, regularity restriction, safety profile, clinical prognostic markers, drug characteristic, patient performance, physician preference, and the patient preference. A lady does not want to gain weight A diabetic does not want to lose his control by steroid, so doctor and patient must share a decision together, and remember that no biomarkers are available for the ITP patient. For the first line, as was mentioned, are clearly discussed by Professor Mervat, prednisolone versus DEXA, and so many studies have elapsed during the past 10 years showing that in the pooled study analysis, there was no difference in the durable, and I mean durable, maintained platelet count response in adults, but a higher rate of initial platelet count was found with additional toxicity in patients receiving DEXA compared to prednisolone, unlikely to what we anticipated. The implication of all of the available evidence high-dose DEXA might be preferred over prednisone by some physicians for adults with severe ITP who require a rapid rise in platelet count. But yet again, the pooled analysis of more than 20 reliable studies showed that there is no durable platelet count response difference between prednisolone versus dexamethasone. What about the adverse event? The cushingoid appearance, the weight gain, gastrointestinal toxicity, peptic ulcer activation, and the lack of control of diabetes. You will find again that there is some difference between DEXA group and the methylprednisolone group, sometimes in favor to the DEXA, and while others are in favor to the prednisolone. Let us go for the ASH guideline 2019 about the initial therapy, as mentioned by Professor Mervat. Steroid, there is no difference between prednisolone and DEXA. Selection depends on patient and physician individual characteristic, the lack of edema or the presence of edema, diabetes, age, comorbidity, and always avoid prolonged use, particularly in younger patients, and be careful to monitor the side effect. Rituximab and DEXA are now considered as an early line of treatment. When you combine them together, this is a more effective combination, which gives a higher response rate within a period and maintain the patient with a durable response for a period at least of 6 months. Fair number of patients in each arm required additional treatment, yet only 60% of those patients maintained their durable response. Lack of data on major bleeding or the quality of life that was covered by Professor Mervat, and the high cost of the medication. Steroid alone are sometimes recommended by the ASH guideline 2019. Let us go for some of the other groups, for example, the international consensus report. Second line treatment will include, as you have seen, adasapril, cyclosporin, cyclophosphamide, danazole, Dapsone, microphenolated rituximab, splenectomy, venca alkaloid, the TPOs, and some may use quinolone or hydroxyquinolone for the treatment of those patients, particularly those lupus patients who have thrombocytopenia. The second line treatment compared to the ASH guideline recommended option 1B, splenectomy, if the patient failed to respond to steroid after a period of 3 to 6 months, TPO agonist for patients in risk of bleeding who relapsed after splenectomy, while other suggested options include the combination of different kinds of TPO. Rituximab may be considered with or without TPO if the patient failed the first line or splenectomy. Again, combining different line of modality, rituximab, splenectomy, TPO are still standard of care and recommended by the revised ASH guideline 2019. Sequencing of second line therapy is also recommended. For example, start by a drug that works early, and at the same time with a drug that works late, and let the nature of sequencing cover the patient for the same period of time. Rituximab and splenectomy, higher remission rate 77% versus 25%, but rituximab and splenectomy sparing patient only 20% response or 30%. So give a bridge of medication, then go for splenectomy. Rituximab is favored by 75%. TPO and splenectomy, another bridge or another sequence that have good safety profile, desirable, undesirable, and undesirable were balanced, and the efficacy goes for the desirable combination. Rituximab and TPO, again, another desirable, durable response in 40% of patients and tolerability in nearly 70%, but this depends on an individual patient characteristic, minded the risk of thrombosis here is a little bit high. If splenectomy is not an option, then TPO over rituximab or rituximab over TPO is considered. If treatment-free remission is desired, rituximab over splenectomy. If rituximab fails, then goes for TPO with splenectomy. So the revised 2019 guideline is a little bit flexible for the second line and gives so many options for those patients. Again, the ICG 2019 showed that first line prednisolone, dexamethasone according to your preference and the comorbid state of the patient. Second line therapy will include high evidence will goes for the TPO, rituximab, fostamatinib, low evidence for goes for the immune suppression. In fact, the role of immune suppression is lacking nowadays, and everything goes for the TPO and the rituximab therapy. Surgical therapy, whether splenectomy by a different kind, is not recommended before the patient failed to respond to 1 to 2 years of therapy. This is another difference between the ICG recommendation and the ASH guideline. A little glimpse on rituximab. The drug has been studied carefully and quite well. Relatively high response rate was observed. Those who are in favor or against the drug goes for the favorable rituximab response. The complete response can be reached in plenty of patients as well as in partial response. This has been documented by Daga et al., Lil et al., Amond et al., and total patient studied was quite enough to judge those patients that they all did well. Limitation, however, half the responding patient relapsed within a period of 2 years. Rituximab at the second line of treatment for adult ITP in the RITPA trial, which is a multi-center double placebo-controlled trial, showed that rituximab therapy, although beneficial, yet a long-term effect is not present, and the 2-year follow-up of those patients demand a further line of treatment. Then the duration of response declined by time and almost lost after a period of 2 years. Retrospective evaluation of rituximab and the salvage therapy in patients with primary ITP with another possible predictor of response has been studied, and you can see here that the long-term response in male and female differ quite, and the long-term response in patient who is above the age of 40 or less than the age of 30, another problem to those patients. There is difference in the response between male and female to rituximab therapy, as well as the age is another risk factor. Clinical parameters that predict the long-term response for prednisone has been studied by many groups, and they have shown that the predictor of prolonged response include a patient who is less than 10-year disease, onset of disease was less than 10 years, less previous therapy. Those who demanded less than 3 lines of therapy usually did better than those who needed more than line of therapy, while others showed that a patient sorry, the ITP duration and the young age is another predictor for the response, and while Basil et al. Showed that less than 2 years and female gender gave the patient a better response to treatment. Another question raises itself: why, who, and when should we consider rituximab as second-line therapy? Remission-inducing therapy, if you need a remission-inducing therapy, a good option during the persistent phase. Individualization should take, particularly in young female with early disease, less than 2 years. Coexisting disease like lupus is another favorable response. Anticipated poor compliance of the patient who will not tolerate oral treatment for long. Patient with high risk of thrombosis and they will not go well with the TPO should go for rituximab therapy as early as possible. Let us go for the thrombopoietin receptor agonist. There are plenty of those agonists of the receptor on the surface of the platelet, and they function and they act like the sword of the platelet to attack other things. Robiplostim, L-Trombobac are two known drugs. Each has a different mechanism of action, and each have a modality, either oral or sub-Q injection. They are indicated in all patients with chronic ITP who are either refractory or not refractory, first line or second line, with or without steroid or immunoglobulin or even splenectomy and immune suppression therapy. The meta-analysis showed that the TBOs significantly increased platelet response and durable response rate. Remember that not only those patients with ITP have a relatively deficiency in the TPO, but relative deficiency in their response of the bone marrow to produce enough platelet. So platelet production and increased destruction goes parallel in the ITP. So the TPO significantly increased this process, as you have seen in the pooled platelet response rate of multiple studies. All are in favor that TPO will go well with most of the patients with ITP. The pooled durable response rate was also in favor for TBO, that they can maintain a patient, whether oral or sub-Q, on a durable response. What about bleeding? The events of bleeding decreased much on those patients who were maintained on TBO therapy compared to those arm of patients who did not take this kind of therapy. Severe bleeding event, not just any bleeding event, was reduced, or where the episodes were reduced in patients receiving TBO compared to those who failed to take this drug. The use of concomitant medication is another issue, and you can see here that more than 8 studies that has studied the value of the TPO in patients on different medication, and you can see the drug was well tolerated in combination with other medication, whether for platelet or for respiratory or cardiovascular disease. Reduced or discontinued concomitant ITP therapy was in favor of those arms of patients who use TPO. They usually were managed quite well by reducing the number of drugs they needed or the line of therapy they needed to be maintained. So eventually you can maintain a patient with chronic ITP on a single line of drug, or maintain on 1 or 2 drugs only. Transient treatment with TPO, or what's called the alternate therapy, or what's called the on-demand therapy, may allow chronic ITP patient to achieve prolonged remission. So it's not necessarily to keep the patient or to push the patient on a continuous way of therapy, yet on-demand may be of value. It's practical, it's less expensive, and will lead to ultimately control an ITP patient in the desirable platelet level. Prediction of remission study in a phase 2 prospective trial has showed that analyzing rates of platelet response was more for those who are platelet count more than 50 to the 10 to the log of 9, 75% with ITP primary, and patient with more than count, or those who are in remission, and no significant predictor of remission was identified in those the studied patient group when they were followed for more than 60 weeks. In summary, tapering may change the paradigm of lifelong treatment. There is evidence to suggest that gradual reduction of dose can allow 20 to 30%, that's to say 1/3 of the ITP patient, to discontinue treatment altogether or to be in a state of treatment-free. Still, they will maintain the response to the TBO once re-challenged again to the drug. Tapering offers many functions. A number of advantages: reduce the cost, reduce the toxicity, potential for improving the quality of life of patient, and the patient will have a lot of hope when he is free of any treatment. This is another crucial point to those patients. So what is the potential pathogenic mechanism of treatment-free remission? This needs to be addressed, and this was seen in the switch study, where you will find that switching agent may be beneficial in patients who fail to respond to or experience adverse effect with the first agent. When you use this switching protocol, this will determine the feasibility of switching from romiplostin to eltrombopag, a question that was raised by Professor Mervat, or vice versa in terms of platelet response and adverse event. So you can use alternate therapy, combined therapy, or on-demand therapy. You have 3 options, or for switch, for interrupted treatment, or alternate kind of therapy. The retrospective multi-center study was conducted in France, investigating the feasibility of switching. 46 patients were enrolled in one study. Platelet count fluctuation as the reason for switching was considered. TBA agonist was the reason that may only cited by the patient initially receiving any plate, and those vice versa. The author concluded that switching agent could be beneficial in patients who fail to respond or experience adverse event with the first agent. TBO switch study result is also very promising for those patients who have fluctuation in their platelet count, and the patient, when shifted from one drug to the other, still maintain a durable and a good response. What about the safety? There has been some concern about cataract in young age group, bone marrow fibrosis, thromboembolism, and other causes. This is the bone marrow fibrosis, as you can see by Jamani et al., where distribution of 4 myelofibrosis grades in pre-treatment, 4 sets of one on treatment and post-treatment bone marrow biopsy. In a patient with ITP receiving romoplostin, bone marrow changes were observed in a rather small population of the patient, and you can find that 3 patients in cohort 1, 3 in cohort 2, and 10 in cohort 2 were judged by biopsy. However, the 5 patients with increase in reticulin by 2 or more grade, excluding those patients with collagen, included 2 patients, and the follow-up showed that this response is a little bit insignificant when they studied those patients. But what is alarming is that one of the patients that was thought to have fibrosis of the bone marrow due to the drug did develop a non-Hodgkin lymphoma, and this was responsible for the changes in the bone marrow of that patient. So, to summarize, bone marrow fibrosis, most patient grade of fibrosis did not change or slightly increased during treatment. Moderate increase in reticulin fibrosis occurred in less than 10% of the patient. Both reticulin and collagen fibrosis regressed in the majority of patients after discontinuation of TBO, and in a few patients, fibrosis regressed despite continuing therapy, but this result was not significant enough. Usually, no change in the number of morphology of peripheral blood cell was seen. There is no consensus on whether how to monitor bone marrow fibrosis among those patients, and still bone marrow biopsy is not of that value or does not need to be done for patients on TBO therapy. The efficacy of TBO, I will go rapidly, for the primary as well as the secondary line, showed there is no substantial difference in thromboembolic events between TBO and control group. Even the RR was 1.008 with 90% confidence, and this is another important issue that needs to be addressed. Do those patients have a higher incidence of thrombotic event or no? So, veno-occlusive disease and thrombotic event were studied by many groups, and again, you will find here that only 6.5% of the patients in one study and only 7 out of 340 patients, that's 2% of patients, developed thrombotic event that was managed in a usual manner and did not impose any mortality or morbidity for those patients. And the duration of follow-up of those patients was by Wang et al. For a period of more than 10 weeks. Remember again, 6% in one study and 24 events in another study, and those patients did well and they were managed quite well. So for the thromboembolism, another concern for the TBO, the incidence is increased in ITP compared to the general population. The incidence, it does not seem to increase in ITP compared with the general population. That's for the other problem. It seems that TBO further increased the risk of VTE, perhaps due to an effect on the platelet and von Willebrand factor on the endothelium. Thrombosis treated patient is not related to the agent, dose, duration of treatment, platelet count. That's to say, you are liberal to read thrombosis in those patients as conventional as you wish, keeping in mind that sometimes heparin may induce thrombocytopenia. Individual risk profile should be considered when initiating treatment with TBO. Previous thromboembolism, splenectomy, presence of antiphospholipid antibody, anti-double-strand DNA, and concomitant medication like estrogenic preparation should be considered. Why should we consider TBO and when? The recommendation for the chronic phase should be considered after failure of steroid with or without steroid. Early phase, patient not expected to respond to rituximab. If rapid response is needed, transient platelet elevation is needed, failure of rituximab. Remember that the anti-D therapy will be failed for those patients who are splenectomized. So there is no need to use an anti-D in patient who underwent splenectomy. What about splenectomy? There is lots of pros and lots of cons. It is curative, maybe. For 60 to 70% of patients, they will not need treatment, but it's not curative, not effective response to other medication, except for the lack of response to an anti-D, known safety profile if the patient will not have the notorious pneumonia or meningitis and he is carefully prepared. What are the cons? Removing healthy organ is very important, particularly in young age, because it's a very important immune modulatory and immune surveillance organ. Short-term complications include mortality, infection, vascular complication, particularly the VTE, long-term infection, vascular cancer, and this is another rising question that you remove the tonsil or the spleen, the risk of cancer is rising, unpredictable response, particularly for age. Rarely we can use NDM scan or other chromium tagged scan to consider which will benefit. However, there are now growing incidents, growing concern in some tests that will show which patient will have the platelet function that will tell to go splenectomy or not. Why should be considered for splenectomy and when? Recommendation by the ASH 2019 to be postponed for at least a period of 1 to 2 years, reserved for adult surgically fit patient less than 60 or 65 years of age, worse overall efficacy and safety in patient more than 60. Patient not responding to other line of second line should be considered. Not recommended before 1 year of disease, secondary ITP, elderly frail patient, patient with hepatic sequestration who are likely to do worse after splenectomy than that. So sequencing of therapy is in 2019. The current practice will go steroid, IVIG, as Professor Mervat mentioned, newly diagnosed 2 to 3 months, rituximab, immunosuppressive alone or in other combination, TBO. If the patient persists after 3 to 12 months, go for splenectomy, and the patient is deemed to be chronic after 12 months, then other agents should be considered, whether quinolones or hydroxyquinone or whatever. You have the luxury to use many drugs. Choice of therapy after failure of steroid in newly diagnosed or persistent based on the current evidence, the age, more than 60 to 70 years, go for TBO and no need for splenectomy. Less than 60 to 70 years, those patients need transient response, bridge the response for another line of treatment, TBO. Need permanent response, need quick response, another things to be asked. Yes, if the patient needs a quick response because he's having a fracture or a cerebral hemorrhage, then as Professor Mervat mentioned, that the drug that will work as an emergency should be considered. If the patient has no permanent response or no quick response, for female, go for rituximab, particularly in the young female. For male, it's better to use the TBO rather than rituximab because the response is much better. And finally, splenectomy, if needed or doomed in those patients with chronic ITP, consider it. Immune suppression are now decreasing its implication or role in the management of ITP, whether this is in an elderly or the younger age group. Finally, fosamatinib is now considered as a new drug that will show better response for patients with ITP. In conclusion, many treatment options are available or have limitation. Indication, choice of treatment, and intensity should be individualized. Individual therapy to obtain the optimum balance of efficacy and tolerability. Patient and physician preference should go hand in hand. Change to individualized therapy include lack of evidence and lack of response. And finally, please never lose hope in the coronavirus area. Thank you very much.
Thank you, Dr. Azazi, for, as usual, up-to-date and to the point presentation. I think it's time for the question. And first, my question about the use of the combined TBO agonist, both of them at the same time.
Well, most of the study, Muhammad, as you know, they use them sequentially. If the patient failed to this, go to that, or intended sequentially without even failure to maintain the response. Use one, shift to other, use one, shift to the other. But you can use both together, yes. in certain severe condition, you are likely to start with, for example, a subcutaneous end plate, then shift to the oral preparation once the emergency is no longer present. So yes, you can use both, and you can use them sequentially, one to the second to the first, but you can use definitely both of them together.
Dr. Walid Ghanem asked about the rate of the splenectomy in Egypt. It's very high rate of splenectomy in Egypt.
It used to be very high, particularly for the young age group. But I think now, with the availability of TBO and other modality of therapy, particularly rituximab, and so many new drugs, and the increased knowledge that splenectomy may fail in patients with hepatic sequestration or other diseases, makes splenectomy not the first choice as it used to be. Remind you that 10 years ago, only steroid and splenectomy or venka alkaloid were available. Now, you have so many new drugs that make splenectomy not the desired treatment, particularly for elderly patients or extremely young age group.
Dr. Walid asked also about the proportion of the patient who fail steroid and go to splenectomy.
I think, yes, since Muhammad, you know that we work in a tertiary referral hospital, and the incidence of patients who are refractory is quite, referred to our center is quite large. I think more than 40% of our patients fill those criteria.
I think this is due to the type of our center, Dr. Azizi. As we are a tertiary center resistant, only we got resistant cases. So a lot of our patients is resistant.
Yeah, we don't admit except a refractory ITP or resistant ITP. Otherwise, they are held in other centers or in an outpatient practice. But again, they are referred because of the seriousness of the condition.
Yes. Dr. Ashraf Ghandour asking about, do you think splenectomy is a tool now with the presence of the TBO?
First, it's nice to hear your voice, Ashraf. We miss you very much in Cairo. But I think splenectomy should be resorted to as the extremely last line of therapy to those patients. I don't think it has a role nowadays, and the role is decreasing by the availability of many drugs.
Dr. Adina Surur asking about, is target therapy indicated for patients for children with the ITP as first line of treatment?
There is controversy about this point, but some of the TBOs now are being accepted for patients as young as 6 year age, which is quite marvelous. But again, I would be hesitant to use this as a first line of treatment. Remember, Muhammad, that in adult, the majority of patients will go for the chronic phase. Unlike the children or the pediatric population, the majority do not go for a chronic phase, and they tend to have a form of an acute ITP or a sort of short-term ITP, as I mentioned it, and they do not go for only 20% of the pediatric population who suffer thrombocytopenia will go for the chronic phase. So you do not need as meticulous or as troublesome therapy as the other population.
Dr. Ahmed Yusri asking about the best second line single treatment for the ITP patient if I want TFR and why. He want to ask about the best second line treatment if you want to cut it shortly and go to the tumor treatment free drugs directly.
Two options. You want to treat the patient because you need to lower the platelet count within a period of 24 hours for surgery or delivery or whatever, then you use the pulse steroid. Rituximab will not work immediately. Immunoglobulin is another option, and we call it, for the poor patient, we use the venka alkaloid because it gives a rapid response, but yet not durable. However, if you have the luxury of not concerned about a time factor, then the TBO will be the drug of choice. You do not cause Cushing or Cushingnoid feature. You do not elevate the blood pressure. You do not cause weight gain. And the well-being of the patient is by far, and the quality of life is better.
There is a question there about your opinion in combining anticoagulant with TPO for high-risk patients with for fear of thrombosis.
Yeah, until recently.
I want to ask about the use of if you will use the anticoagulant with the TPO for fear of thrombosis for your patient.
In 2012, there was this guideline, particularly the British guideline. They recommended in 2010, it was very popular, and 2012, they start to question this, whether you use in the patient who have very severe thrombocytopenia, you can use an anticoagulant therapy or not. But careful meta-analysis and better understanding of those patients, you find that some of them had a sort of a DIC-like picture. Others have antiphospholipid syndrome that were not present at the time of diagnosis. And eventually, those patients who needed anticoagulation therapy did not do by any means better. In fact, the mortality was high, and this practice does not exist anymore. In fact, in the ASH guideline 2019, they condemned the use of any kind of anticoagulation as a trial or a salvage therapy to an ITP patient. Better clarify that this patient is not an ITP rather than a secondary form of thrombocytopenia, and most of those patients turn out to be secondary form thrombocytopenia. I mean, for example, you see Muhammad Lupus patient where he's having uncorrectable thrombocytopenia with frequent thromboembolic event, and he is anticoagulable or antiphospholipid positive, for example, or a patient with CTB or a patient with HELP. So I don't think this practice should be used any day nowadays.
I think, Dr. Azazi, the best option for the patient is to control the platelet count to be less than 200,000.
Yeah.
There is only still two questions. Yes. What are the predictors to response to the steroid? There is a predictor to the response to the steroid for the patient?
Usually, there was some reticulated platelet and other tests, but there is no predictor for either DEXA or prednisolone that will tell you which is which. There were some predictor for rituximab and TPO, particularly the gender and the younger age group and the female gender, but for the steroid, still, at least for the Egyptian population, there is no reliable predictor to which will respond to what.
Can we use the TPO, Dr. Azazi, in patient is going to surgical procedure as an emergency measure?
Some have used this line of treatment, but it will not give you a durable response, but you need this response after the surgery. So, yes, you can use it, but you don't expect that this will give the patient the benefit to go to surgery immediately, but you need this response after the patient goes for come out of the surgical theater. He will need the long-term response. So again, use a short-acting, rapid-acting drug and a long-acting drug, combine them together to get the best results possible.
I make a study 2010 Dr. Azazi, about the use of TPO agonists, mainly romoplastin, is a patient with chronic liver disease who is going to make an elective operation.
And you were the first to do this, despite the criticism of others, and you proved to be correct. It can be used, and it's now used. Remember, there was much antagonist to you, but you managed to prove that it is effective. Yeah.
Thank you, Professor Dr. Azazi, for this presentation, and
thank you very much,
and thank you, AMGEN, for this night, and thank you all.
Good evening, all of you. I don't see the attendance, but thank you for attending this meeting. Thanks for AMGEN. Thanks for Mr. Ahmed Yusri from ICOM. And I would like to thank AMGEN and our speakers today, Dr. Walid Ghanima. Thank you very much for to be with us today, and Dr. Ashraf Al Ghamdoud, Dr. Mervat Matar, Dr. Muhammad Azazi, because this is the last session. So I thank all of you, and I know the last speaker today is Professor Dr. Muhammad Abdul Mouti, who is a professor of Medical Oncology National Cancer Institute, Cairo. Dr. Muhammad Abdul Mouti will talk about the challenges in a case presentation in ITP patient. Fadal, Dr. Muhammad.
Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank Professor Rafat for presenting me, and to thank all the moderator and speakers for this fruitful session. وكل سنة وانتم طيبين بمناسبة شهر رمضان إن شاء الله بعد بكرة أو بكرة يعني بمعنى صح. أنا هتكلم على very interesting case. Our case is a 25-year-old woman with symptoms such as bleeding, rashes, petechial rashes on part of the body, bleeding from gums and nose, and heavy menstrual flow with no evidence of fibroids or endometriosis. During her examination, she showed multiple petechial rashes all over the body with normal weight and average height, febrile with no splenomegaly. No personal family history of cancer, autoimmune disease, no recent viral illness, no bone pains, no night sweats. She is on current medication for pain like the results of CBC was platelet count of 19, hemoglobin 9, white blood cell count of 10, negative anti-double-strand DNA. Therefore, the final diagnosis was ITP. Initial treatment was with prednisone 1 milligram per kg per day for several months, and the results of CBC were as follows: platelet 11.6, and white blood cells was 12. After several cycles of treatment, CBC results showed refractoriness to treatment, and the physician asked for bone marrow aspiration. Bone marrow aspiration showed normal number of megakaryocytes with less platelet attachment. Accordingly, the treatment was continued as IVIG. After 4 months, due to results of relatively low platelet count in the patient, the first-line treatment failed, and in the next action, she was subjected for splenectomy. Shortly after splenectomy, the patient suddenly decided to be pregnant. Therefore, according to the patient condition, treatment with steroids was performed in the first trimester of pregnancy. Abdominal ultrasound indicated progression of normal pregnancy. However, the platelet count did not increase significantly, and since the patient was passing pregnancy and approaching delivery, the decision was taken to use romiplastin. After 3 cycles of romiplastin for 3 weeks, the response to treatment was good, and her platelet count was about 164. In the partition, the platelet count was 75, and she gave birth of a healthy baby with vaginal delivery. And after delivery, the patient platelet count was still good, and now the treatment with romiplastin continued for her, and the patient is in favorable condition, and her baby also. Our patient has unique characteristics like pregnancy during treatment, refractoriness to first and second line treatment, a positive response to treatment using romiplastin without any fatal complication, and successful delivery. I will revise what have been seen quickly. As mentioned by Professor Ashraf, ITP is defined as a platelet count less than 100 in absence of obvious underlying cause of thrombocytopenia. It can be newly diagnosed or persistent or chronic ITP. The patient came with bleeding from any orifices, like without any substantial or constitutional symptoms like weight loss or bone pains. And the CBC only should be done and only showed isolated thrombocytopenia. HB pylori testing is in the last guideline should be done in adult. However, it was controversial in children. Virology, all patients with ITP should undergo testing for HIV and HCV, and for us also hepatitis B surface antigen. And it is important to say that bone marrow examination in the ASH guideline 2011 and in the updated guidelines last year, it should not be done irrespective of the age presenting with typical ITP, and it is done only in any patient presenting with systemic symptoms or abnormal signs or abnormalities in the CBCA or peripheral blood smears. But again, the treatment should be done if the platelet is less than 30. Patient below 30 should be managed by observation. Patient with a platelet count less than 20 can be managed as inpatient. Above 20, they can be managed as outpatient. First-line treatment, again, is in favor of short course of prednisone or dexamethasone, and the addition of rituximab is done in very selected cases. What about the TEPO agonist? TPO regulates the maturation of megakaryocytes and through signal transduction pathways into platelet-producing cells. And the ITP is thought to be a mixture of presence of anti-platelet antibody leading to accelerated platelet destruction, also suboptimal platelet production. And the most therapies for ITP is targeting the reduced platelet destruction, while TPO receptor agonist is a new treatment option aimed at increasing platelet production and thus overcome the increased destruction. It can, both TPO can manage to bind and activate the normal TPO or stimulating platelet production at various sites of the TPO, and the rate of megakaryocyte production maturation is increased through this drug through the same way as endogenous TPO. Revising quickly the studies of romiblastin in ITP, in comparing romiblastin versus placebo, the durable platelet effect was better with romiblastin, both in splenectomized and non-splenectomized patients. Also, the overall platelet response was better with romiblastin than those with placebo, and the bleeding effects were grade 3 or 2 or more or 3 or more was lower with romiblastin, and the proportion of patients receiving rescue medication was lower in patients receiving the active treatment. And the patient with romiblastin arm has at least 25% dose reduction in the concurrent ITP therapy, and the duration to response with romiblastin increase were seen within 1 or 2 weeks. And the side effects were tolerable and mild, mostly due to headache and fatigue and epistaxis, and there was no difference in the study profile of romiblastin between splenectomized and non-splenectomized patients. When we compare the romiblastin versus standard of care, again, rate of treatment failure was lower with romiblastin, the rate of splenectomy is lower with romiblastin, and the rate of platelet response was 2.3 times more with romiblastin, and the headache and fatigue were the most common side effect with romiblastin, and 23% of romiblastin arm shown severe adverse effect versus 37 with standard of care, and the treatment-related severe adverse effect was only 5% with romiblastin versus 8% with standard of care arm. Lastly, when we review the up to 5 years of weekly treatment with romiblastin in more than about 300 adult ITP patients in a long-term single-arm open-label essential study, again, adverse effect, treatment-related adverse effect occur in 1/3 of patients, and if you are treatment-related serious adverse effect in 8%, thrombotic effect again is occurring is about 6%. Only 2 patients out of 300 patients showed a normal neutralizing antibody to romiblastin, and they disappear on resting from the drug for drug withdrawal, and they showed no cross-reactive antibody to endogenous TPO. And throughout the study, the median platelet count were above 50,000 were maintained with a stable doses. So with romiblastin, a platelet response was achieved in at least 95% of patients, and 67% were able to maintain acceptable platelet count. The most interesting is that patients who self-administered themselves were able to maintain a platelet count response at a 70% of all time, and they achieve platelet count of above 100,000 in more than 90% of patients. What about the comparison of splenectomy and TPO? Splenectomy, of course, has a chance. It's a century of experience. It leads to response in about 2/3 of patients. Open splenectomy is equal in laparoscopic splenectomy. It is the only curative treatment of chronic ITP. True contraindication are rare except comorbidities and old age. Low perioperative mortality of less than 2%, 0.2%. Relatively inexpensive procedure, especially in countries with no socioeconomic standards. Patient reluctancy is very important disadvantage. 1/3 of patients lead to early treatment failure. Overwhelming post-splenectomy infection is a side effect of splenectomy. The risk of thrombosis and the lifelong immunosuppression requirement of chronic prophylactic antibiotic use in some patients. TPO, on the other hand, has the advantage of highly effective in increasing platelet count. It is approved in adult and pediatric. It is a non-surgical daily oral agent, weekly subcutaneous injection. However, it leads a chronic administration and limited long-term safety data with a potential cost of chronic treatment. And the standard of care, according to the last ASH guidelines, for second line, thrombopoietin agonists based the individual patient preference, L-thrombomag in patient preferring daily oral treatment, taking care of food-drug interactions, or romoblastin in patient referring weekly subcutaneous injection, or rituximab and splenectomy. However, we should, as said before, splenectomy should be delayed for at least 1 year after diagnosis because of the potential for spontaneous remission in the first year. And the choice of treatment, as said by Professor Ghanima, as second line, depend on duration of ITP, frequency, comorbidities, adherence, cost, availability, patient education, and decision making. And according to this, patient who place a high value of achieving a durable response may prefer splenectomy. Patient who have to avoid long-term medication may prefer splenectomy or rituximab. And on the other hand, patient who wish to avoid surgery may prefer TPO or rituximab. And this is a scheme for managing those patients by second line, previously mentioned. Coming to our case again, thrombocytopenia pregnancy occurred to many causes. It may be isolated thrombocytopenia due to pregnancy specific, like the gestational thrombocytopenia occurring in a various degree in about 2/3 of patients, or not pregnancy specific, like primary ITP in 1% of patients, secondary ITP is in less than 1%, drug-induced thrombocytopenia, type 2 von Willebrand disease, congenital thrombocytopenia. It can be thrombocytopenia associated with other syndromes as a pregnancy-related, like severe eclampsia, HELLP syndrome, and acute fatty liver of pregnancy, and also non-pregnancy specific, like TTP, HUS, systemic lupus erythematosus, and antiphospholipid syndrome. Regarding the treatment, first-line treatment in pregnancy include oral steroids or IVIG. Second line may include a combination of steroids and IVIG and splenectomy in the second trimester. The third line, not recommended but used in pregnancy, was described like cyclosporin A, TPO agonist, rituximab, relatively contraindicated like azathioprine. However, there are many reports denoting that the use of azathioprine in pregnancy is safe, especially in the second and third trimester, and there are some drugs absolutely contraindicated during pregnancy, like mycophenolatoin, cyclophosphamide, vinca-alkaloids, adenosine. During pregnancy, romoblastin during pregnancy in the toxicity studies carried out on animals, no evidence of fetal harm was observed in romoblastin doses up to 11 times in rats and 82 times in rabbits, the maximum human dose based on systemic exposure. However, in the past years, due to lack of human studies and the adverse effect in some animal studies, it was recommended that romoblastin should not be used routinely during pregnancy. However, in a few studies, their treatment, and we will see, the treatment of refractory ITP patient with romoblastin has been reported during pregnancy without a fatal or maternal complication, and the majority of these studies agree that starting to receive romoblastin from week 20 onwards. And a very nice review published only 2 weeks ago, reviewing the only 9 cases reporting the use of romoblastin during pregnancy. As we can see from 5 authors, most of them were young. Most of them was usually on previous romoblastin, and the antepartum platelet count was very good in most of patients, from ranging from 100 to 200,000, and the postpartum platelet was good, and the delivery was mainly vaginal. In one case, it was cesarean. The maternal complication is mainly due to the ITP regarding epistaxis, petechiae, bleeding gums, ecchymosis, and vaginal bleeding, and the newborn complication occur in 2 patients only in the form of increased intracranial hemorrhage due to newborn thrombocytopenia, and in one case hypoglycemia due to the use of insulin during pregnancy. To conclude our study, to conclude our presentation, with the use of romoblastin for ITP, who has a response rate ranging in most of patients, is approved for chronic ITP in adult in 2008, and for pediatric 2 years ago, increase the quality of life, and decrease the need of rescue medication, decrease the bleeding complication, and a few side effects, mainly headache, fatigue, diarrhea, and nasopharyngitis, with a very isolated case of bone fibrosis. After results of case reports published in the literature, it seems that romoblastin does not produce side effects, neither to the pregnant woman nor to the fetus, and we stated that this is an off-label use of the drug. It should not be encouraged on the white population. It should be used in very selected patients under the medical supervision. To end, it is the end of my studies. I'm waiting for many questions, comment, and I expect to be very interesting, inshallah.
Thanks, Professor Dr. Abdelmouty. I think you summarize and give the conclusion for all the data given today. And we are waiting for question. I don't see any questions until now. If you see question from your side, you can answer it.
It seems that it's very clear.
I think this is very clear because you summarized and concluded all the data come today. So thank you, and we will end the session today.
Thank you, Professor Rafat, and thank you all of you, and happy Ramadan, inshallah.
إن شاء الله كل سنة وانتم طيبين جميعا.